real quick. We're all here except for roll call for staff or right here. So approval minutes. They were emailed out to us.
I move to accept as presented. Second.
All in favor, say aye.
Aye.
Proceeding. Quick comment period. Then we'll start our business. Director and staff update.
Good. Thank you. So a couple of things that I wanted to note. Today is really more of an informational meeting for all of you. We don't have any items to vote on. Please feel free to stop the floor, ask questions. You know, we just want to just further increase your understanding of how we operate and what we do. And so we've got instead of just one item today, we've got 2 items to increase your just general awareness. Moving into the next, wanted to mention that we have administrator feedback on a couple of positions. We have due to a bit of internal reorganization of the CD team, and we're in the process of confirming Jackie as our new community supervisor, which has been doing an interim role. And, so that's in process, and with that change, we had assigned essentially Jackie's nurse role to pandemic, and so we added a position to our communicable disease team just for that. And with Jackie taking the supervisor role, we're not going to continue that position in communicable disease. Instead, we'll be utilizing that most likely in Healthy Lifespan Division, which is where the position actually came from originally, and we just didn't fill it there. We've been having some discussions internally about, you know, what kind of programming we're looking at. What do we want to do with that position? We've been exploring some options in chronic disease prevention that we've not done before. So we really have not had an active programming with prevention for chronic diseases like diabetes, pre-diabetes, although we've had some, you know, nutrition, physical activity, obesity programming in the past, but not since pre-pandemic. We've not done any work really with heart disease, you know, high blood pressure prevention, you know, assurance of treatment, that sort of thing. And those, you know, these are all diseases that typically take decades to emerge, unless we're talking about like type 1 diabetes. And those diseases that take a very long time to emerge are often related to, you know, the environment that you grow up in, behavioral choices, lifestyles, and really bring us back towards, you know, what we consider like our social determinants of health, you know, where you live, what are the environmental factors around you in terms of, you know, education and transportation, poverty, and, you know, all of those issues that have an impact on health. So that's one area of that, and really there's probably more than enough work for one person just in that alone. But the state is writing for a number of grants from Health and Human Services on chronic disease management. So we're in discussion with the state about how we might be able to be a part of that. So in addition to utilizing the funding authority that we currently have in the budget for that position, to leverage that with some new funding that's coming down from the feds in chronic disease management. In February, we will have a retirement of another nurse. Doing a little planning around how to fill that position, but we have a little opportunity here to you know, think really about where we want to prioritize some additional work moving forward, and very interested in thoughts that the Board of Health has about things you would like to see or gaps that you feel like we have, deficiencies that we currently have just because we don't have enough capacity. You know, just what do you see as potentially some areas that we should be considering that I just wanted to offer that up for discussion today, you know, with the Board of Health members. We'll continue to do planning, but certainly appreciate any guidance or advice that you begin to want to give us. And I know I'm putting you on the spot.
So I mean, I think the chronic, I mean, as a background of a family doctor, that's a lot of what we do. And I think like there definitely are a lot of gaps for chronic disease stuff. So like I would be definitely in favor of that. I think one of the big gaps that we see for folks is med costs, especially costs of insulin. So if we could do anything to help with kind of, because I mean, I have a number of patients who say, you know, why is your diabetes better control? Why is this bad? I have to decide between food runs insulin, and I'd rather live to eat than buy my insulin. So then they're cutting it down. I think that's definitely if I would say, well, what I have agreed with things some support in that would be good. And just teaching.
Your insulin that I heard it's like maybe $200 a bottle, is that correct?
I'm not 100% sure, and it definitely can be. Like, I know that it's been going up, and I think 5 years ago, I know like a bottle of the Lancet with the long-acting insulin, I think was around $120 if you were cash patient. I know a lot of seniors they get into that donut hole area. That can be a problem for them. I know that they've been doing various things to look at that, but yeah, I mean, I think especially some of the better insulins, there are cheaper insulins out there, but they're much harder to use. You're much more likely to have low blood sugars and things like that. So getting kind of the better quality stuff, I think is that's easier to use. It's one of those things where you have people who are struggling anyway, and then you're saying, okay, well now you have insulin and you need to make sure you eat at this point and all this other stuff. So it's not going to work. So.
It says here that the average cash price for insulin rose 54% in 5 years. And they look at it price per unit.
Yeah, and I mean, for some folks, like I think the like a bottle of insulin, what does that do? Like there are some folks who their diabetes is kind of hard to control. They go through 2 or 3 bottles a month. So it's, I mean, that's almost a house.
Another that's about 140.
140 dollars a bottle.
In some more context from our Healthy Lifespan division, we've really focused in the last decade about falls and more recently social isolation and transportation. Mental health is a big thing. So as our nurses were coming back from their work on COVID and getting back into the homes, big concerns were just people being able to manage their medication, as you say, and then getting access to those things. The support networks have kind of fallen through more isolation, and just needing more kind of home care or getting them back into a routine. So that's what our nurses are seeing as well.
Another 9 to 10%. So they're not really classified yet, but they're progressing towards same amount for asthma in the population, roughly 10%. And then for high blood pressure, I believe that's a lot higher. I want to say at least 25%. It may be higher than that. And half of people that have high blood pressure don't know they have high blood pressure. and many don't treat high blood pressure, have high blood pressure, and don't, which, you know, has those, you know, after decades of high blood pressure, you know, has consequences on health in a variety of organ systems. And I think, you know, we're learning more, even more notably, maybe more about mental, you know, dementia diseases with high blood pressure level. So, I mean, it's an area that I feel like is worth some investment, but we already work on so many things. Sometimes it's hard to, you know, add something else to the plate that we have. And maybe we should, you know, sometimes we just need to focus a little bit harder on some of the core areas that we have, just because we only have so much.
How do those numbers, those percentages, which you gave, how do those relate to other parts of the country? Are we where everybody else is, or higher, lower?
Probably at near the bottom, you know, third, excuse me, the bottom of the top third in terms of lifestyle and health. And you know, we look at rankings of Wisconsin is in the nation. It's like, so an example would be the Trust for America's Health rankings just came out. Wisconsin was ranked number 21 out of 50 states in terms of all of the indicators that they measured. In terms of diseases related to alcohol consumption, obesity, you know, we rate pretty high, you know, or poorly, and certainly, you know, another chronic illness, you know, is high cholesterol, which is related a lot to our diet. Well, you know, high blood pressure is not far behind in terms of, I mean, it's higher, but it's we see a lot of that co-occurring in people. So I can't give you a great answer on that.
So I pulled up. I found it kind of interesting when I was looking at the stuff that they sent out about the ranking. So I guess we're ranked. Which actually I was somewhat surprised. Obesity over age 18, we're ranked 23rd. So one being good. So we're above middle of the road, which I thought we were a little better. About the same with chronic disease, so we're kind of middle of the road. We seem to be kind of low on vegetable consumption, which looking outside might not.
Yeah.
But I mean, we also have a lot of farmers, so I think that. So we're not kind of mediocre.
Considering our investments and
yeah. And I mean, I think like with the kind of disease stuff, obviously we have 3 very strong health systems in our
Three very what?
Strong health systems in our county. We have State of Care, we have Ascension, and we have Aurora. So like we're obviously doing a ton on trying to do the chronic disease stuff. So, but I think any sort of partnerships that we can do with the health department. So I'm wondering if that may be one of those things, like part of the role is kind of a collaboration, more collaborative role than a direct service role, to be like, all right, what do you guys need us to do? Or vice versa, back and forth, to be like, hey, is promotion good? Is going out to help out farmers who aren't coming in for blood pressure checks and seeing how they're doing? Is that good?
Actually, I got a meeting with your medical
team. Carl,
yeah, medical,
yeah, Dr. Kelly.
Yeah, in the beginning. You guys, priorities about that.
Please come to mind. Well, number one, what's coming up with affordable marijuana. And lifestyle. Will we do any work in that area?
We've monitored things in the past. We've not done much work in the marijuana area. We do have a drug-free communities program. The emphasis of that program is to reduce substance use among youth. Our priority areas, their primary area is really alcohol.
And marijuana are the two
marijuana, we haven't done much
identified
lately.
so Hannah, we know yeah, great water, which is just mentioning. That group has been doing work to make sure that they're talking to people and understanding of the impact of marijuana, legalization of marijuana, especially related to our youth and how that impacts youth. Hannah is also coordinating actually a statewide hemp derivatives group to take a more increased look at what all of the Delta 8, 9, 10, and all of those sorts of people that are popping up for our community, how that is and what that all looks like. So right now we're really in a kind of research, greater understanding. So we'll really be equipped to provide some good support and information when those things do begin, when those conversations do begin in our community.
A lot of people for it, right? And so there's data here about what the impacts of all economic related to legalization.
A lot of that stuff, we got the smoking, we got the side of the product every day and smoking a lot. If you watch the TV commercial now or a show where they smoke way back when they keep burning it now. Now marijuana's going to do the same thing. So I know my group way back in the days, that was okay, that was legal. Now it's like it's just petty. Police don't want to spend a lot of time doing people just a small amount about a bigger amount. But to me, the things I've noticed, even in alcohol, I went to classes where they graduated. Some people went to the program that got in trouble, but got out of it by doing that. Me, it seemed like these things are passed down to generations. When I went to this one thing, I saw mom and dad had drug problems. Grandma had drug problems. And their daughter now has drug problems. And now all I could think is they all were crying and upset, but their kids, they protect the kids. But now, to me, it's like, you really got to do a lot more with the kids because there's a pattern there. I mean, I went through 3 or 4 generations now. I don't care if it's marijuana or if it's drugs or anything. The kids, we really got the kids. Even the vaping now, the kids, and that's a lot of children that's okay to do, But the kids really aren't. I get you see this pattern, and I said, well, I just don't want to see it 2 years from now. Now their kids are in this program, and what can we do with those people? How do we get to the kids more in school? Or parents, I always said the parents are supposed to do it. They should. The teachers don't. But somehow we have to get to them before all this, because now money, this marijuana, the dollars you sent to the state to make all this fun. Now what do? I just feel the kids are somehow need to. I don't know, training more. We got to get out more forward, more things in school, like mentoring or what. Just see that coming. Well, I know, but it's not really something we do. I think it's taxpayers are going to decide.
It's the same cycle we see with property, with domestic violence. I mean, it's all breaking the cycle. And how do we use resources best to, break that cycle, get people into recovery? And so often, when we talk about what's the parental role here, it's like it's always put on what parents need to do about it. That's not working, right? And so what are the other interventions that we can do? How can we apply resources in a way that helps break that cycle?
Right. It's hard. Single parents. I mean, there's no other person that can guide them. Grandma and grandpa can't because they've been through it. I mean, I think I said it with this one. Mom was there crying, they're upset. Dad didn't want nothing to do with it. So I think it's ridiculous. They're torn, And, they just keep worrying about the kids. That's where next level. Not about money. And how do you get the people to come in? The other thing is I noticed, we get the ones that walk in and come and do this, but what about they're sitting at home and don't take advantage of any of the services we got. How do we reach more of them? How do we get to? They can't all be. I mean, they're poor, don't have a car, can't get out of the house, don't have any money to do this, can't do this. You want to insect the family, such a home, pass around the house because you can't get out. How do we get more of them to come in? That's yeah. Things I noticed like that.
Yeah, there was. I did a little bit of just a really small amount of work with Breakwater Group last spring, winter, or something like time.
It blends together.
But we actually had because one of the things was, well, how do you get to it? How do you reach it? So we were doing sort of a podcast type of thing. So it's you can start reading the paper, not really what you do. So it's like, well, what if you're really doing a PSA? It's not like the more you know on a setting. So we had and I think a lot of that related to the breakwater stuff. And I know that we did a whole big discussion, and it was meant to be kind of a non-judgmental thing. All right, marijuana is coming. What are we supposed to do? And we had some sort of, hey, let's have a real discussion of what are the real dangers, what aren't dangers, how does it go? So I know that some of that stuff has been up there. And I guess the question is, do we take some of the stuff we already produced and elevate it and put it into the sphere so that's just the word?
Before those podcasts came out, this was summer of 21, Breakwater also did a series in about marijuana. So I think Dr. Smolnik is saying right. There's been a lot of things that are out there that we bring back up and we promote. And as far as working directly with youth, I think one of the cool things that Dr. Smolnik reminded me of is one of the other things that podcast did. So the Breakwater Coalition got involved with the Oshkosh North Youth Program, and so there were several students from that program that chose to work with Anna and the Breakwater Coalition through this past school year, and they actually took over the podcast. They had a couple of high school students that were creating podcasts and interviewing other students anonymously to talk about drugs and where they're getting their information from. Gave us a lot of and so that's all on their website, and I would really at it. Breakwater was that.
I think it's yours. I pray Scott. He's gone to a lot of school all across the country, and I went to a couple of that. You always think kids aren't going to respond. But you're in there when you have somebody that's been involved in certain things. You're really respectful. And they listen to me. I always thought I was involved. We've never.
Yeah.
Town here, but she this suicide. She really pushes his foundation to prevent youth suicide. American Idol. She's from locally. She really does a lot with kids. Oh,
He's just sharing.
He's in her early 20s. I think she's like 20.
Speaking of that, thank you for the resources. We brought some extra cards right next to you. There's 2 sets of cards there. One is a We Heart You card. which helps connect people to mental health and other services through 211. So new mental health connection and 211, and the other is about free Narcan, free Narcan. You know, to the extent that you go anywhere in the community, you can drop some little cards off someplace, you know, anywhere. And so I just brought a few for you to grab in case people go to places that you can just leave them.
I'm always around. So, you know, I love everything.
And we have lots of them, so take care of that.
It's the thing you got to keep talking about. I mean, really say you're part of this. Really got to bring up your conversation. It's not really digging down. I think people just they want to be social, but you know, how many times you walk past somebody and they really don't look at you? They kind of look this way. I hate that. My wife says I'm going to get in trouble because I talk to kids and people on fire, but you need to do that because you really don't know what's going on here. You have no idea. If you talk to somebody, spend some time with them, deeper in what's going on. She might be able to help me in something. I might help her. But I think we all have to do that more. Talk about what we have. And again, that's one thing is what I've learned in the last 9 months, 10 months. There's a lot more to the stuff than people. And every time I talk to somebody, oh, that's not true. You better come out here and find out. You're going to class or you're going. That's just mind-boggling. That's all. They need to get up. People need to get involved. Stop complaining, stop lying, start doing it.
One of the things that several you work on is social connectivity. We are exploring that.
Great, I appreciate what you guys do. I was talking. Made a mistake where I didn't ask questions, I didn't get more involved. Never going to do that again. But I'm doing it now, and it's really people. Appreciate it.
One thing about we come up in the state, you know, legalization is use. So it makes it safer because it's regulated. So I mean, it's kind of it almost seems counterintuitive, but you know, some of the dangers in the black market is that it's completely unregulated. So there's some benefits to legalization by keeping the supply safer. And in other states that have legalized when it first started, like in Colorado and Washington, they I guess earmarked some of the tax revenue for prevention. So they had millions of dollars in at the state level. They never had that kind of resource for prevention. And particularly in Washington, they created campaigns really geared towards kids, to educate them, to really talk about the myths and reality. And so there's it's a 21 and older kind of thing, and it's trying to reduce the black market and really try to like less access for kids. So there's some things that can actually benefit legalization that aren't, it's not aimed at getting access to it. It's trying to do that.
We saw that thing needed. Yeah, what's regulated, a lot less contaminants. And
yeah, they're right. So,
other stuff that they can get, which I was assuming a minor is illegal, correct? So that kind of makes it black market for them.
it does. It does.
So, I think that's a bogus argument. So that
they were able to put a lot more money into and their connections and which I mean there's no just at the state level in the state they didn't have any money for prevention. So that's just something.
Was like the prevention campaign effective? Like did they be less used?
They the one in Washington, they worked with kids directly, back and forth for the marketing campaign to say, what did the kids want? They wanted the truth. There's a lot of myth out there. And so they wanted the truth, and they provided the truth, and and they didn't want scare tactics. And so they went back and forth with youth, and sometimes they didn't believe them. They thought they were trying to scare them, and no, this is for like everything. But they, by being more truthful and not tactics, or and having youth involved in developing the campaign.
One of the kind of the weird regulation things going in marijuana right now is that so like there's the CBD product and Delta 8 product, they're basically protected under the federal farm bills that we passed in the last couple of years, and what so right now Delta 8, which is there is no regulation on it. So if you are 6 and you go to a store and buy it, you can. Now, luckily in our area, I think most of the people who are selling the products have some like D2D tobacco things. You can't do if you're under 21, you can't do stuff like that. So the industry itself has a little bit of regulation for it, but like that's it. So there is like, and that particular product, this is the black market. Whoever wants to go in and buy it, can buy it.
So that is a THC product.
Yeah.
And it is available or is not available?
It is available. Yeah. Yeah. So it has like if you do like when I do drug screens, people test positive for THC who are supposedly exclusively using Delta 8. So.
But it's from hemp. That's why it's not from marijuana, it's from hemp. And so marijuana is just a whole different animal than it used to be in the way that it's processed and concentrated. And so in hemp, very, very low percentage of psychoactive THC or THC-like products. And by processing very large amounts of hemp and concentrating that, you end up with a very potent psychoactive type of drug that's legal.
Obviously.
Thank you for some of that feedback. If you have other thoughts about how to guide some of that programming for us, or the things you'd like us to take a look at or work on, just reach out to them. We'll be working on this. A couple very quickly, just a couple of quick updates. This is the time of year where we finish up our negotiations with the state, any contracts that we have with them, that we've finished all of that. Each of our divisions are working on and finalizing action plans for next year. Just to kind of prioritize where our divisions is going for next year. Another large project that's underway is where the codification of the money code. So we're looking at how we're going to update the public health code. Most of that work right now is in environmental. We've got a number of areas where we can improve and update our code in environmental health. That'll be most of the changes that we offer for review to. And with that, I'm going to move on because we're going to run out of time today again. So with the Ann, you want to give a quick update?
Sure, a couple things for environmental health. The lead grant, we have the LSHIP lead grant and HUD lead grant. Right now we have 12 properties that are enrolled. And of those, 1 is ready for the abatement work to start and 3 others are in the bidding process. So Scott started that program in May. He had to undergo training, he had to get contractors, get properties. So it's really been rolling along quite nicely.
Yeah, it's because of the number of properties that we've been able to inspect and now enroll. If we can get them to the point of actual abatement, get contractors hired, we may have to go back to the state and ask for more money because it's been more successful than we thought it would be initially. So, which is great.
We also are in partnership with the state of Wisconsin to test high priority daycares. Those daycares are the licensed group daycares and the Head Start programs for testing of their water systems. We're contracted to do about 10 daycares with the ability to do more if we have the time. What that entails is we would go out to the daycare, we would test water, first draw water samples from the every faucet in the building to check for lead. And mainly we're looking to see if the faucets are bad, you know, that they're leaching lead into the water through the faucets or the pipes themselves. If that's the case, then the state, but what we find, if we find a high lead level in the water, the state takes over, hires a plumber to do an evaluation, switch out the faucets, resample, and try to get that daycare water lead free. So that's going to probably start in January or February. So more information to follow on that. For our transient non-community water systems, those are the water systems that are that serve at least 25 people 60 days out of the year. They're mainly our county bars, churches, restaurants. We finished up sampling our 124 wells, and resampling starts in January. It gets sampled every year. So we do that. It takes us pretty much all year to get those done. Sanitarian, we did hire a new environmental health specialist. Her name is Maeve Casey. She actually graduated from UWO Environmental Health Program this Saturday, and she's going to start with us on January 3rd. And she'll be training with the other inspectors for 4 to 6 months, probably at least. And I know this is what you guys have been waiting for, the establishments, new establishments. So we have a couple new establishments. There's a Ruse Roadhouse, which is a little bar out in Eureka. It used to be the Starlight Bar, reopened as Ruse Roadhouse. I think it's opening tomorrow. We have an Airbnb in the town of Winnebago on Lake Poygan. That is the most gorgeous Airbnb you could ever stay in. And then Thunderbird Bakery is opening a retail store in Oshkosh. We have a couple plan reviews for new construction. We're getting a Noodles in Neenah and the Panda Express in Oshkosh, which you guys are probably aware of, and a couple of change of owners. The Amro Fish Inn and Amro Inn and Amro changed hands. The Doubletree in Neenah changed hands. The Lions Den in Oshkosh changed hands. And JB Airpus and Fox Crossing changed hands. So anytime we have a change of owner, we have to go in, do an inspection, making sure that they're up to code. Because some things are grandfathered in under previous owners, and then when they open, they may have to add a food prep sink, they may have to add food faucets like that. So they have to be brought up to code at the time of change of owner. So we do a full inspection and then get them relicensed at change of owner. So the second to the last one that you read in Oshkosh, you said it was a Lion Den?
Yep, the Lions Den Bar on 6th and Idaho.
Oh, I was gonna say, I see these big signs. I thought that was a porch.
Well, it is. There is one.
Okay, that's not it.
No, 26. Yeah, that's out on 26.
Okay, yeah, the porch signs.
We used to do those. Used to do peer pleasure and video.
What were you looking
for? Yeah, we had to inspect the video. For
lighting,
lighting, curtains, right? All in a day's work. Well, right now we have nothing. But we, because I think the pleasure was the last one that was on Oshkosh House. More than you wanted to know?
Just think, I've seen these. Out there.
Environmental health everywhere. Lions Den had a fire. Yep, it was Jake's bar, and then it was the Lions Den, and then it burned down, and there you go. But that is, if you guys partake, that is like the cleanest bar ever. You could. You got
check out that Airbnb.
The Airbnb. Oh my gosh, that's gorgeous. That is the most gorgeous. That was the most gorgeous view I've ever seen in an Airbnb. It looked out onto Lake Poygan. It was. Oh. Yeah, there's a bunch out on Lake Poygan. That's all for you.
I am a supervisor Community Health and Prevention Division. As a side note, I realized this morning that I'm participating in an educational program that runs several months at the beginning of next year. And it conflicts with all of our Board of Health meetings. So I will not see you all again probably until next summer, but we'll have somebody else from CHP coming in my place. So a few quick updates. In housing, we're really focusing on affordable housing, and there's a coalition that formed at the state level that is digging into what that could look like in narrowing down the areas. Funding policies as far as our good work goes, the Great Water Coalition grant, which we've talked about quite a bit already, launched the Beach Break Harold. I think that's so if you haven't read that already, it's a really good article to what you were talking about earlier. The whole idea of Beach Break is encouraging adults to talk to youth about substances, about mental health, about all of those things. You know, Be Courageous. As part of that same series, they're also a series of parent panel discussions with health providers, substance use providers, law enforcement, school districts, and a wide variety of folks talking through kind of how parents can have that discussion and changing trends in drugs and what drugs look like in the parents to be able to know what's happening. There's some changing things happening with it, some changes happening with some of those funding streams. DFC and all of the drug-free coalitions historically have been really, really prevention focused, meaning that they haven't been able to get into the arena of harm reduction, Narcan, any of those sorts of pieces. And with kind of nationwide increase in overdose, DFC is really changing their tune. And so there's going to be some state opioid response funds coming through to Breakwater to purchasing the Terra bags, which are state medications, and help promote some harm reduction. Right now, Breakwater is working on a program with one of the local pharmacies where we will supply the pharmacy with the Terra bags. And then when certain high-risk overdose medications are prescribed, the pharmacist will send out Terra bags with the medication. So people have medication. Still in that substance use umbrella, we have a lot of work that we do in the overdose fatality review team. You may have seen some articles in the paper, but OFR was Chief Dyka from the National Department with the first ever We Heart You Award of Excellence. He's retiring and he's done a lot of work in all of our local communities and with OFR in just overdose prevention and substance use awareness. And so that was just to be exciting day last week that we were able to present him with that award. That team also is working on a We Heart You app. It's in beta testing mode right now and should be launched early next year. But the idea of that app is really to be able to have an easy way to connect people into a wide variety of services, treatment, recovery, Narcan, kind of all of the things. So I've been able to play around with that app quite a bit, and I think it's going to be a really useful tool, though. They're just working out some kinks. But that app will also connect in with the solutions peer response team. So within that app, there will be a 24/7 call or text feature that can connect people with a peer recovery coach. So some exciting things next year. And then, as I mentioned, the solutions peer response team has been active through some grant funds that we were able to secure since September. They are still primarily working with the jail. There's a huge need there, and we know that people, when they're released from incarceration, are often at a high risk of death by overdose. And so there's peer support folks, peer recovery coaches going directly into the jail, taking people up, bringing them directly to recovery meetings when they're released. So since September, their numbers that they're providing back is that they have had 14 successful connections to outside help, 3 immediate transports from the jail directly to residential treatment, and 11 connections to sober living. And of those 14 connections, 12 of them they're saying are currently sober and in treatment. So for a program that just launched in September, we're pretty excited about the data that's coming back. In harm reduction, we are working on providing Narcan training in Oshkosh area school district. So far that's been done a couple of times with primarily social workers and nurses, but I think it's open to any OASC staff that are interested. So there'll be a second round of those training in January. Also been working with some classes through PW Fox City. And our harm reduction program coordinator, Amanda Tempson, is certified to provide HIV and Hep C testing. So that is launching this week, actually. So of our clients that we service in our Lifeline harm reduction program, we're now going to be able to feed in that population, or a service we're really providing. And then lastly, related to transportation, one of the staff in CHP, Susan Garcia Franz, is serving on the Community Safety Action Plan Committee, which is looking at all the bipartisan infrastructure legislation that's coming down and working with East Central Regional Planning to develop criteria for transportation projects that are going to be funded through this legislation.
I have a question.
Yeah.
The bags these pharmacists are handing out, you dispose of them and then put them where?
In the garbage.
Just in your whole garbage.
Yep. There's like I don't know the whole.
There's an active ingredient that you put your pills in, and once you put the water in, you shake it up and it dissolves like the active drug ingredients. Just turns.
Yeah.
Everything I'm seeing, the rents way high. I mean, the average Joe can't, let alone trying to get the first apartment. And I know in somewhere in town there's a different housing rate, kind of off Main Street originally. It was all set up to be government. They have that was the original plan. And I know as the years go by, I know people are trying to get into those apartments with better incomes. They're charging more rent. They're not doing the affordable housing. I don't know if you're coming across this. I know the intent was there, but it's not there. What I'm hearing, and I've had friends that were trying to do apartments, and it's tough to get one. You know, anything in your credit, they won't let you have one. And it's $1,000. It's not 5 or 6 or something hundred that people need to do. And I'm noticing a lot, like I said, these ones that got the grant to get the cheaper building of the project to put 4 people in there aren't doing it now 2 or 3 years later. Do you watch that or do you check that? Or?
Yeah, I have a very, very incredible team of strategists that work in the division that do a lot of things, and I don't know all of the things that they know, but I think that the understanding of what's happening, and I think what they're finding is that there's no easy solution to any of this. And that's why they're really focusing on what those state level priorities are going to be, because that kind of support from the state allows us locally to have a little bit more backbone support in moving some of those affordable housing priorities.
Yeah. So our participation in Starting With right now is incredible. We're at about 215 or 2015, and our caseload is projected at around 1,998. So we're over 100%, and our no-show rate, because we kind of do a hybrid now with, You know, we're remote and we offer it in person. Because of that, our no-show rate is at 4%, which anything lower than 10% is, you know, as far as the state level is huge. So really working on outreach right now for WIC, Parent Connection, doing an MOU with Parent Connection over there, trying to complete the circle, trying to, you know, when they leave our office, we don't want to just send them out and then see you in 3 months. We want people to be checking on them if they're needed, if it's needed, if they're high risk. So MOU with Parent Connection is going out right now. Father Cars wants to also combine services. And what's hard about Father Cars is they can't take their groceries to their rooms. And so that's what's hard about being a part of WIC. And then also, you know what I mean, living at Father Cars is that we have to have a place for them to put their food. And all of them, you know, obviously, if they're going to live there. So that's something I'm trying to work out with them. Bella, obviously downtown too by Target. We're also in connection with them. Just, you know, referrals of service is really what we're trying to get back to after the pandemic, because everything kind of filled out a little bit. We're in kind of when, you know, rogue, nobody was doing any kind of referrals really to any other people. It kind of stayed in-house. So trying to get back to completing the circles of care, continuity of care. And besides that, I don't think I have much else. There's a proposed WIC package changes from the federal government, like taking out juice, because we all know juice is not exactly the healthiest. Taking out juice from the food package that we give, because we're finding obviously a problem with dental and a problem with increased sugar-sweetened beverages in kids, increasing their BMI. So they're thinking about taking it out completely or reducing it. And other things they're proposed in the package is like including some of those lactose-free items like almond milk and some of the things that we don't include right now. You know, some of those other alternative to dairy packages, because we have so many little ones right now that need it, that have allergies and things to nuts and seeds and other kind of preservatives. So that's it, I think. Is and we're working on marketing. We're with the marketing staff right now. We have we're trying to put together a project where we have 30-minute little like blips on WIC and then putting them out into social media. So we're working together with Ashley Mikasa to try to do that. So because we have the ability to do that right now for this year. So which is a good thing, and trying to get the word out in their venues, those young moms. So
I just have a multi-part question.
Yes.
So Father Cars feeds people, don't they?
Yes, they do.
Then why do, a couple questions. Why do they need WIC? And if the stuff they're getting is formula, they can't keep formula in their rooms? How do you trust that someone's not messing with your baby's formula if you're storing it in a yeah.
Well, that's the issue. That's kind of the things we have to work out, because there is specific rules to Father Cars, and there's a shelter there, and they want them to commune. So they want that to be part of the healing. So that's why they don't want you to have food in. They don't want you to go into the shelter and then never come out. Like go in your room and never come out. So that's why they include the food part of it, as you have to come down and eat with us. We need you to talk to other people. We need you to heal. That's part
baby
of it.
Formula.
Yeah, the baby formula thing. And that's something we'll have to. Yeah, maybe we can exclude that. We haven't gotten that yet.
Well, it's not up to you to exclude it.
Right.
It's up to Father Carter to say, Father Carter's group to say, women can keep baby formula in their rooms. But that's not your rule.
Yeah, no, meaning we would have to work that out. If we're going to partner, we're going to refer to them. We're going to take our participants and say there's a safe place for you at Father Cars, but they won't let you keep their formula there. That's what we have to work out. Like, how would that work? What would that look like? Yes. Or is there a way we can have a secure, you know what I mean? I don't know, cubby. And then come down, still get the formula and then bring it back up. I don't know. That's all.
We warn young women, don't leave your drink unattended.
Well, right.
Make sure you see the bartender pour it and nobody touches your drink. And yet we're leaving baby formula out in the open. And
well, that's not happening yet. I don't know what they're having. If they're part of the bank, I don't know yet what they're, so I don't know what they're having with moms do. Because that would be a question is, well, are you not allowing them to have formula in their rooms to feed the baby at 3 in the morning, you know, when you're not commuting, you know? So that's a question for sure. That's a good, very good question.
fight for that.
I will fight for it.
Thank you.
We'll fight for it. Yes.
I worked in the fire department, EBT,
Yes.
in Wichita too.
Yep.
But during the summer, we used to have 4 pages, people come and get food.
Yeah.
In the winter, they don't travel.
Right.
So now, and I have to see the moms if they have the money to they gotta get out and get it.
Right. Right.
Thank you.
Like they were thinking.
So you think.
Right. Well, I know, I mean, food kitchens, I know we go to a lot, but in food pantries, but again, yeah, they don't go out much if they don't have transportation and they're not taking their kids out on the buses. And so yeah, that's a question. What WIC is trying to do is get the ability to have the delivery system or the pickup. It's just that's years behind that. So I couldn't tell you. I know our Somalian population, they will come. We just can't figure it out. They will come to every WIC appointment, come hell or high water. They will be here in the snowstorm and whatever. They do not redeem their WIC benefits. They do not. So we don't, yeah, they do not redeem their WIC benefits. Now, we have the part, and I think it's a language barrier thing, and I don't know if they think that they have to because of being in the country and whatnot, but they do not do it. We cannot figure it out. And there's some, you know what I mean, there's other non-English speaking population that does the same thing, and even English speaking population sometimes will come to every appointment, will make every effort to be here or have the calls and will not redeem them. So we don't know. We cannot figure it out. We'll ask them and they'll say, yep, I'm going to do it. I'm going to do it next month. And they still do not do it. So we cannot figure it out. So I can't answer that question now. So that's a tough one. I don't know. I have no idea. Yeah.
Question kind of looking at environmental services. What types of do you guys do screening for the
Screening as far as what? Health screening?
Yeah, for like that or for
Yes. So we do. And it was better when we saw people in person more often. But right now we are linking with the, healthcare systems to try to get that data. But we used to do it in-house, and we're starting to do it more now. Like there's a barrier with WIC though, that we cannot take lead with a child unless it's with the same hope for hemoglobin. So like we can't just pull somebody in and say we're going to check for lead. They would have to be in for an appointment with us to do hemoglobin too, and then also do the lab. But yes, we usually collaborate. All of us. And we are actually with Scott right now. We are actually collaborating with his program, his lead in, what she was talking about with the residential lead, safe homes. We are trying to refer more to them now. Like, hey, are you living in a rental? And trying to do some mini screenings. But there again, WIC likes to put some barriers on that. Like, hey, you're not supposed to do any screening that's not our own risk assessment. But we do. I'm going to tell you, we do.
Have some vague idea that.
Yeah. Yes, the big idea would be.
Yeah, we're also trying to make sure anybody that store door that they are clear and stuff.
Yes.
That's always one of those things where it's like, well, do I need to stick the baby?
Yeah. Well, yeah.
Or did WIC stick the baby?
Yeah. Yeah.
lead is if the child hasn't had a blood lead test by 18 months.
Yeah.
If we try to send reminders with participants, you know, the I-9 visit or the 12-month visit to remind their primary care provider to do a lead test. Everyone in the WIC is considered high risk, so all of those should be tested.
But there was a huge gap between after the pandemic because they thought we were doing it and we thought they were doing it. And then when they realized they don't come into WIC, but they will go to their providers still, then the providers started opening more for leads again. Yeah. So, but in usual basis, we don't know what it's going to look like in the future, but we would have done it already.
Yeah, and then also usually there's usually some daycare homes or stuff like that that are trying to remind you, hey, what's the what's the issues in life? So I think it's supposed to be a year. I think yeah, a year. It was 3 before 3, right? 3 before 3, and then like
yeah,
and then another checkup before 5 or something. So
yeah,
your lead checks. So that's like robust lead program now.
well, yeah, you can help it.
Sometimes it was like, well, what are we testing for?
Yeah,
Like,
we can't do anything, but yeah, now there is.
So I'm just going to. Sarah Jean with epidemiology, she's having car problems right now, so she did send me her. She's really working right now and looking at that has come out of the Youth Risk Behavior Survey, or the YRBS. And this is a survey that schools adopt or agree to participate in, and it's an anonymous survey that the students, the middle and high school students, fill out, and it covers, oh my gosh, it's a long survey. It's online, and they use class time for the students to do it. So there's a commitment of the schools to gather this data, and it's really looking at youth risk behavior. So it talks about nutrition, smoking, vaping, substance use, suicidal ideation, mental health, sexual risky behaviors, violence, all kinds of stuff. And it's a very robust set of data that we also use to help inform some of the work that we do, specifically tailored towards. So Sarah Jean is closely looking at this big data set, and so she will share with the health department. We have used YRBS data for decades to really inform some of it. She is also assisting staff on the multiple and diverse data needs that each division requires or needs, creating efficiencies and processes, data reporting, easier analysis of data, etc. She's also collaborating very closely with Heidi, for example, our planner, on the community health assessment, on division action plans, etc. So she's a pretty busy girl. Planning, Heidi, she's working with a team of community members on the ensuring processes that are following framework, and she's going to be presenting later on today on one of those frameworks. Making sure that how we do things meets the requirements to becoming an accredited ready department. I mean, she's working on a lot of different things, and I'm just summarizing, so I apologize if I leave something out, but she's also doing workforce development related staff trainings. So one of the things that includes is we don't want to offer trainings just to offer trainings. We want to make sure that the trainings we're offering are meaningful for our staff. So going to our staff and saying, what are your needs in terms of professional development. So she's working on that. And really coordinating with other divisions to establish next year's action plans and a lot of other projects. Emergency preparedness. Do you want me to just summarize?
Go ahead, I'll just fill in.
She's really the go-to staff person on testing, on COVID testing and vaccine clinic coordination. There's been a lot of different little things coming in and out related to vaccine availability, scheduling, coordinating with pharmacies and other community partnerships. So she's really the person for that. She's also working with 211 to ensure that the most up-to-date public health information is available to residents when they call 211. So I think she found out that there were a lot of outdated things. So doing other community outreach as well with pharmacy and other. She's also involved in a very robust new to public health training that the state puts out. And it's year-long, it takes a lot of time. So she's now 3 months in, so she's got another 9 months. And then keeping us all very prepared for the nasty weather and winter, and really helping our staff.
So the one thing that I'll point out, and all that we're partnering with Hometown Pharmacy right now to come to our COVID vaccine clinics out at Sunnyview to offer flu shots. Last week we did almost as many flu shots as we did COVID shots. The community really likes the free service of being able to walk in. We don't provide it. It's a corner booth separate from us. They come in to get their COVID shot, or we've had a number of people just come in to get their flu shot. And it's working really well for Hometown to gain those folks. The population that we're seeing is every age. It's not just senior citizens getting caught up in their flu shot. We had an 18-year-old this week. So it's a great service. Walk-in is such a good way to capture people who are looking for that service.
Thank you. Our communications specialist, another very busy lady. She's working on marketing and promotion of work of other divisions. So she works very closely with each division. What are your promotion needs? What are your marketing needs? What are your communication needs? What are your media needs? That takes a lot of time. Press releases, situation updates on our website, new programs that may be coming up or updates to new programs. Oh my goodness. Social media monitoring. Right now, she has the daunting task of redesigning our website. So the county, as you know, has a new website. And in the transition, a lot of links no longer worked. A lot of sites no longer were available. So we have the biggest website in the county because there's so much information in our department. So she is working very diligently on that. She is a great asset to our team. Along with that, she is working on our annual report. It's due in March to the state. So she starts working on this October, November, to summarize basically an executive summary. Any questions?
I have one more thing. There's a new program called telehealth. So if somebody tests positive on a COVID home test or one of the local test sites, they can enroll in the program and get free medications for that. So they can get Paxlovid. So they call the telehealth number or they go on the website after they've tested positive, and they work with a healthcare provider through Colors. I'm not sure if you're familiar with Colors. It's like any healthcare system that's offsite. And then they can screen through the process. And if they want to get a free prescription for Paxlovid, they can certainly get that. So that's offered. We have that flyer out in every one of our vaccine clinics, every one of our antigen test pickup sites, the libraries, human services, wherever we have free test kits. But it's something you can do anywhere. You get a test kit from Walgreens and you want to call the program, you can call the program. And those can be found on our website or the DHS website. And it's a free program to anybody.
I had an opportunity to get them. And the screening was call a number, and you first get a person who's like, let me just see if you qualify.
It's a screener.
And then if you qualify, you leave your number, and then the practitioner can usually and she again goes through almost exactly the same screening questions, and then determines if you're a candidate, and then calls in the prescription to your pharmacy.
Or it can be delivered directly to your house by UPS. The one thing that they do, they screen really hard certain medical conditions, so just that the average person is going to get that free prescription and have a healthcare or health problem that would disqualify them from using that medication. So it's not just a, oh, I get free drugs on my phone. It's a healthcare provider, there's practitioner, a PA, or a physician on that second call that's going to go through that. And if they have certain conditions, they will actually go in and look up their medical records to validate some of that information before they give them that prescription. The Paxlovid comes directly. So it's not their physician that they're talking to. Their physician is going to have to, on the phone provider that they get, is going to have to reach out to their healthcare system to validate that information, or they're going to have to connect in some way or fashion to make sure that's appropriate.
When you start talking about Paxlovid, made me think, what do we know about the shortages of children's flu medications in our community, in our county? That's on the national news all the time, but I don't know what the situation is here.
Yeah, I'm not.
The shortage, no.
Okay.
No. Are you talking about like Tylenol?
No, Tamiflu, right?
Yeah, the things they've been able to get for children. Well, maybe some of it may be children's Tylenol.
Yeah, because there's like non-official shortage area of town.
There is or is not, did you say?
There is an unofficial, official, like, I don't know how to say it. So like when you go right now, you cannot find Tylenol.
You cannot.
Not that brand. And that brand. Yeah.
You can get the store brand Tylenol.
Store brand. Yeah.
And amoxicillin is in shortage too.
Oh yeah, that was the other thing I was hearing about. Okay.
Actually, Mike put in the chat for the admin. He's curious what we're doing, the work that the grant was rejected. The county executive said he put money in the budget to do that work. So I'm guessing.
Yeah, the grant that Heidi had successfully written for and supported and rejected. So I think Heidi has date.
Yeah, I would say 75% of it went to Esther, which is a nonprofit group in this area. And then 25% went to Wisconsin People's Health Association, and they also wrote for a successful grant. We wanted to keep it local, and it had to go to somebody that was already awarded the grant. So it worked out well to have Esther and WPHA, who's working on the community health assessment, community health improvement plan. They have a facilitator, consultant working with a group of local departments, trying to improve the charge-ship process.
So we contacted the state, trying to work with them on all those funds we get redistributed. Some of them we were fortunate to find other applicants locally that we could work with, and that will some of those funds. In terms of the intent of the funds originally, as a part of our community health needs assessment process, we'll continue to collect data, for that process. Everything defined specifically for exactly what that project was yet, but it's our intent to continue to collect information for that process.
We still got the funds.
We had to have those. We couldn't accept those funds. We worked with the state to find another organization to accept those. So that we had some control to direct them, and so we were able to find two organizations that could accept those funds. We're willing to accept those funds. And so we're working with them on that process.
But we are still conducting the work.
It sounded like second time that it was more like not taking money from them, but there's places be ARPA or guys for 800,000 we had. That's what they talked about. The money coming so much you were still going to do it. So
we still have to do work regardless.
right. There were other places money was coming from. That's so. You still do it. Yeah. Look at that.
And that's the community health assessment.
Oh,
we're going to start doing some focus groups in early 2023. So we haven't started. We've collected secondary data, so from the different data sources, that kind of thing, and we haven't started yet.
Part of that was going to be rolled out to not employees, but the party. I think they do their work, like half of it.
The original grant?
Yes.
The original grant would have allowed us to hire a contractor. We'd probably end up doing more of that on our own.
So then that contractor won't be hired.
Right.
Okay.
Working on a community health assessment is a year-long process. It's very robust and rigorous work. So, and Sarah Jean as well as other staff from community health prevention division. So, public health departments. Hospital systems, healthcare systems, are, if they want to keep their tax exempt status, have to conduct a community health needs assessment every 3 years. We're a very small community, so for 3 healthcare systems to start asking questions of the community and us doing it every 5 years, it's a lot of burden on them. So public health departments and healthcare systems work together to do one community health assessment, or at least to try to collect the same data that then we can all take back to our original sites and then analyze it accordingly. So we collaborate with healthcare systems to do that. However, because of COVID, we have not been able to do that this year, so we're doing it this year. But for the past 20 years or so, we've always done it collaboratively with all the healthcare systems. But yeah, it is a requirement of our statute.
Breaking influenza like illnesses, very much the rise earlier than we normally do, which comes in December, late December, January, January and February. That's all been happening much earlier this year. Hospitalizations and people going to their physicians, stopping. We're seeing a lot of RSV, which is currently trending downward, followed by COVID and flu are currently rising. There's some rhinovirus out there, and a lot of those illnesses. The flu vaccine is available this year. It is going to be a very good match to the circulating viruses that we're seeing in influenza. Only 31% of Wisconsinites though have received their flu vaccine. So we're not sure that the 18-year-old talking about it. So I knew that was mine. Did not intentionally plan on going in there. Was never a discussion. When I said, "Oh, you have flu vaccine," I was just going to be around grandparents now that this holiday season, and so make sure that across the state, our community levels, COVID are on the rise. See that, first people are taking that home test, so we're not always to know that people who stop in for their physicians are going to urgent care, so they are tracking those as they're going out. But we're seeing wastewater. 15% increase in the total number of cases though in our jurisdiction. So those are people that are testing either for their workplace or health. Again, talk about our mobile clinics in the Fox Valley. Doing well with that. We're seeing an increase in schools. We sent out a letter this week to give them a little more support as they're having absenteeism. People are calling in with those influenza-like illness symptoms. You may not know exactly what they're ill with if they don't go in or they don't test, but that happens. So reminding parents when to take their children. So we're seeing that in schools and child care. We are having a discussion working on our TB. Talk about latent TB has been a problem during the pandemic that people weren't getting in and being seen. Currently, when we have people with latent TB, we're sending them to our local organizations to get treated. People go to Wisconsin program against community concern. Wisconsin will provide treatment for them. We've just set up working with Aurora. And Aurora, not yet. We haven't gotten them on board, but Data and Ascension, which is access to see our patients so they get their medications ordered.
All right, for the Healthy Lifespan Division, we kind of think of ourselves in 3 teams. One of the teams being the family child health area. So we were successful with the budget process. Thank you guys for bringing in that grant money, $150,000 over the next 18 months to help our families. And so January, we're really going to hit the ground with our parent resource hours. And to address your question earlier, Ralph, about how do we connect with these families, our goal is really to start building more community peer-to-peer. So engaging with our community, finding out people that have been through WIC, that have used the other programs that have been successful with utilizing the resources and having them take that message. Sometimes we at the health department always aren't the best ones to be at the ground level. So it's kind of a train the trainer type of system that we hope by the end of next year, we have more peers running these parent classes and bringing people together to make their own systems of support within the community. We are submitting our scope of work and the budget to the grant this week. And so that is all finalized and done. If anybody wants to see really how that lays out 10 pages of scope of work, you can, I included it in the link for the notes later. Well Woman program. So we are seeing the highest levels of enrollment in a decade. And in 2012, that's when the Affordable Care Act happened. And so prior to that, many more women needed this insurance program. And so we saw the numbers really go down in 2012 and kind of been dwindling. COVID was again hard when we pulled some of our staff capacity. But in January of this year, we implemented a new patient database that has been a game changer. It's really helped clean up the whole caseload, make sure that reminders and enrollments are happening on time. And then our staff were able to put more energy into updating our materials. We've got more materials in Spanish, updated brochures, reaching out to those 9 counties and their providers and our partners out there to make sure the referral process is happening. Promoting healthy aging. So that's the older adult healthy aging aspect that we talked about in the beginning. Definitely looking at the chronic disease prevention programs the state can offer, what we're already doing. We talked about a few things here today: medication management, mental health, social connection. The nurses really feel too, someone to come in and run these programs needs a medical background. We went back and forth about how we hire that. So Teresa Paulus, who's been with us for over 30 years, she's a retiring nurse, will be posting for her position, but really looking for someone that wants to come in with that strategy mindset of connecting our healthcare systems, our private and our public all together to find some of these healthy aging solutions. And I think I'll share a little screen here. These are our numbers for the Wellness Plus classes. Oh, of course, show up there. So Joanne is the coordinator for our Wellness Plus Coalition. We work very closely with Health and Human Services, ADRC on this. And
she just had her coalition meeting last week and was able to pull together a lot of the statistics. So I was just going to show you, we had over 400 people participate in classes, and considering that the beginning of this year was still COVID lockdowns, that is really exciting. We hosted 28 classes around the county. 6 different types of classes were offered. And the big highlights is we're starting to build back our leaders. For a while there, we just had attrition of losing leaders, people that used to be able to do it through their work no longer had capacity. Joanne was trying to move a lot of the classes forward on herself. So we're really excited to have these numbers not only as strong as they were 3 years ago, but improving as well. And that is all for Healthy Lifespan, unless there's questions. Yeah.
Statement review.
Yep. Sent you 2 documents. One was the more detailed income statement. Right now, as a part of our total budget goes, this is through November. We should be at roughly 92% of our expenditures for the year. We are at for income, we're at 70% of budget, our additional funds in our budget that we had brought in for things like COVID or whatever. Most of that is reimbursable expenses. So if we don't spend it, we won't incur those. We won't receive those funds. Relative to expenses, we're at 68% of budget. So we're doing fine. Our current surplus, is on the last page. You can see it's about 373,000, running about like we did last year. And then please remember that we're also our revenues typically lag behind. So we'll be several $100,000 under budget this year. We did plan to use up to 800,000 of our reserve this year. Whatever is not spent up to that 800,000, or that we have in surplus up to 800,000, will just remain in our fund balance. So budget looks good. I won't spend a lot of time on it. We've got a little ways to go yet, but happy to answer any questions you have about any of the details.
You said budget looks good, but we're showing a deficit of $373,000.
That's actually, well, so if you look to the column to the left, the revised budget, that 830,000, that was a planned deficit in order to utilize the public health reserve to offset levy.
Okay.
So what happened? So in this document, and if you look on page at the bottom of page 1, the transfers in, that is our levy transfer in, and you can see that our levy for this year is 1.862 million. That is reduced by 800,000 from what our levy normally is, because we're using the health department reserve, and that's why we have a projected shortfall of 830,000. That's all coming out of reserve. Currently, and I just in parentheses, and I know it's a deficit. We're actually running, our revenues are running ahead of our expenses by 373,000. So we're in very good financial shape. Yep, we touched on a bit of that already. Keeping this on here so that you kind of know what's happening. You guys help me out. I'm missing something here. Monkeypox, we have not seen a case of monkeypox in Wisconsin in many weeks now. We still continue to offer monkeypox vaccine to populations that are at higher risk. We'll continue to do so. On the COVID front, you've heard a bit of an update already. I mean, kind of in a nutshell, we're maintaining our clinics for vaccine and for testing. We're promoting use of self-tests as much as possible. We've been creating a renewed program for self-testing people in order to get online. You heard about Sunnyview and offering flu vaccine along with COVID. Cases are rising again. We expect them to continue to rise. The new variants that are circulating are not a great match for the current vaccine. They are working to prevent severe illness, but they're not nearly as effective now as they were in preventing, general illness. So becoming infected and becoming symptomatic. And because of that, because of the increase in transmission that we're seeing, we are seeing an increase in hospitalizations in addition to the other respiratory illnesses that are driving some of that now. Hopefully we won't be straining our healthcare systems too much, but it's not unlikely that there's going to be a fairly significant increase in hospitalizations yet to occur this respiratory season. So we're still promoting vaccine particularly for those that are at highest risk of severe disease. And those are going to be our seniors, our long-term care facilities, and we'll continue to work with that. The current rate of vaccination for those that are up to date remains relatively low. We'd like to see that increase. However, as time goes on right now and the newest variants are becoming the predominant virus, the vaccine is it's helpful, but not as helpful as it used to be. So it's not a great situation. It looks like that, another booster would be most helpful at this point, but we don't have one developed. So I don't know if anything that's coming down the pipeline for that either.
No. And right now, community level, well, if we continue on the same trajectory,
and that's with not a lot of testing occurring. We're kind of running a bit blind in terms of how much illness is in the community for COVID because people are testing at home and it's not getting reported. So we're using other indicators like hospitalizations, percent positivity testing rate, and any other indicators we can get from state surveillance. Wastewater levels are increasing. Yeah. Wastewater, the state coordinates a wastewater testing program. The Oshkosh wastewater district participates in that program, so we get very local data from Oshkosh on the amount of virus in wastewater. Appleton participates, and then we get a statewide picture of what wastewater looks like across the state. We get a report about every week. Just got one yesterday. Definitely shows that wastewater levels are increasing in many areas of the state, and certainly here in Oshkosh.
Vaccine, again, I know a while back you said that we wanted to get vaccinated 65%. I remember 4 or 5 shots per hour up to. I imagine each one's getting harder and harder.
Yeah, the percentage of up to date, I don't think anybody has that handy. It's like,
I think it was
Say that again.
I think it was 12% of people have had full every vaccine. Yeah.
Being updated.
But yeah,
Current. Current.
Yeah, and I think it sort of depends on risks and stuff like that. I think basically virtually everybody is eligible for it. And the higher people are 5.
Correct.
I don't know, have you seen, I know you were talking a little bit about the walking products about previous volume. Are other vaccine sites, do people go there? Is there much, have people still getting vaccinated, right?
So talking to the HERC region coordinators that are my like partners in other counties, the ones that are still running vaccine clinics are seeing numbers about the same as what we're seeing. They're not dying off completely, but they're fairly low. They're under 100 now on average, but they're still seeing people come in every week. So people are still seeking out vaccine.
And the 65 plus rates are much better. Yeah. So we're definitely targeting that population in them.
isn't built. So many people are getting information to go to get their second, third shot. They got COVID the second, third time. Keep the shots trying to get away from COVID. So there's a lot of information from doctors, which go along the line, which kind of telling people, don't take the fourth, get the fifth one because it's not going to work. It's not going to work. You've got COVID all the time. You're sick. So I don't know how we doing on that kind of communication. That's kind of what's making the number high. Right?
Yeah, I mean, physicians are making, judgments based on a person's, current risk and risk of any side effects from the vaccine. People that are most protected have had vaccine and have had an infection. Those people are really in the best position in terms of not getting reoccurring or probably more importantly, a severe illness that's going to result in hospitalization. They don't know if we're going to see a change in recommendations for who is most eligible or prioritized for vaccine. Right now, it's available for all ages, basically. But we're, as I mentioned before, the vaccine isn't preventing disease, it's preventing severe disease. And people are not taking many precautions and spreading it to others. So we're going to see a lot more.
Just the stories that are coming into the vaccine clinic might be interesting for you to hear. People are coming in anticipating holiday gatherings because they know it's there and people aren't wearing masks anymore and they want the best coverage. There's a gentleman that came in this Wednesday to give his story some airtime. He knew that he was going to be what he called a super spreader because he knew nobody was going to be wearing a mask. He timed his shot to be 2.5 weeks before that. So he had the highest level of coverage in his mind because he knew he was probably going to come down with COVID because there was going to be people in that required audience because it was for work that he was going to get sick. And he wanted to make sure, he goes, well, at least if I get sick, I won't get really sick. And that was his goal. And that's really kind of the message we say at clinics now. It's like, it's not going to stop it. It's just going to make you go through it a little better and not be as severe. And we are starting to see, and you probably can see this, speak to this more than we can, people who have repetitive cases of COVID, the long-term effects of damage from that is starting to be visible in data now. So what's the term that they call it? Not long COVID. There's a different word. No, it's after you've had it more than one time, the damage that.
Oh, that one.
I think it doesn't. I think it's multiple organs. I think it's anything and everything. That's what I'm reading. But there's not enough studies yet. Yeah.
Okay.
Sorry,
I was like, I don't think that's the computer.
I'm about to say no for you. I don't know exactly how to say this. These sort of anecdotal comments about people who've been getting COVID 2 or 3 times who've had the vaccine. If they've had it a second time and a third time, it means they've lived in order to have that outbreak a second and third time. In the 3 months before the first shots were available, I'm not even sure they were on the horizon. I lost 6 friends in 7 weeks from COVID. A couple were younger than I was, a couple were about my age, a couple were older. So it's hard to say, well, were they too old or were they whatever? They were various age groups, but some were young, a couple were younger than I am. And so complaining that, well, they had the shot, but they're still getting sick and then they're getting it again, but they're not dying. They're not ending up in the hospital being on a ventilator because they are in the process of actively dying and then die. The shots are working. Yes, we're still getting COVID. And unlike other diseases, from what I've heard, additional outbreaks of COVID that you might get, you think, well, once you've gotten COVID, somehow you've got this sort of, like other diseases, you've got an immunity somehow. Well, you don't. You can still keep getting it. You're not building up an immunity. The shots are important. My 6 friends would still be alive today if they had managed to hang on 3 more months until the first shots came out. So they're getting a second bout, they're getting a third bout,
they're getting those extra bouts because they didn't die.
There's a lot you could talk to the side. That's one saying. It's two sides, not just one side. I never had a shot. Hundreds of thousands of people, no mask on. They don't have, but I got real bad. And I lost a friend too, just like you. But I don't know. And I hear it all the time because people tell me all the time. There's no person. I'm not saying what yours is wrong. It all happens. But all I'm saying is whatever we do in life, we can't do people that's stable. Stuff is coming from doctors. You know, everyone's told to talk, trust or not. Now, there's people are going to start saying that your doctor's told that doctors not have right information. That's not good either. There's a long story. There's a study going on. And all the shots are so all of the years to get that. This was kind of, yeah, I'm not saying it's good or bad. I'm saying they're on different things like you. So I respect everything that I'm not taking a side of. I can say one has a different opinion based on what their doctor or their. We all got to get together. Okay. Experience so much of this. Just concerned about people getting information that it's really kind of true from their doctor, but they've been told that they're whack or they're not, and they don't even talk to anybody because they're scared to tell anybody. It's how I believe because you don't believe like I do. I'm not trying to teach you, I'm just saying. So many people want to tell their story, what's going on, but they're scared to detect that saying something. Yeah, there was justice. There's no fact. It's for fact. It's okay. Something happened. But when you hear every day that we're on 4th and 5th vaccination for this vaccination, it's not going to work. You know, people think different. Just saying, God bless what everybody does and everybody knows and figure out what people do. But a person in the middle was apart with a mask on. There's nobody out there. Person driving around all day in their car with a mask. Is that really working out? I see more and more people that go in huge crowds. There's starting to be a few more people. There's tons. I went to EA and I didn't see a mask in all places. 650,000 people asking. So it's a little different thoughts. But this can't refuse the thoughts that people have. You have to deal with that. I mean, I know our best work for me, I think it's talking about. I just have a feeling of closer to people. What's going on? They do good stuff. I'm not saying that. We just have to listen to more stuff. I know. Communicate with people rather than just arguing about science.
And that's part of the survey that's going to be done next
right.
year. That public survey that we turned down funding, but wasn't it to ask people?
It was asked about their experience.
Yes, and to hear both sides. Right. So
I think, you know, I'd like to believe that we're, you know, beyond the point of, you know, you're right and you're wrong here. I think it's a matter of, you know, vaccines have served a great purpose. Lots of illnesses and deaths have been prevented. The virus will continue to evolve, just like flu every year. You know, we need a new vaccine, and so we'll continue to see changes. Getting vaccinated doesn't mean you're not going to get sick. Doesn't mean you're not going to die, but we know that it's protective and it's helpful. And from that standpoint, it's been successful. Not as successful as we would hope it would have been, but you know, clearly, you know, as a society, I think we've moved on from, you know, we're not doing vaccine checks anymore. Travel, we've pretty much accepted that it's a part of what we do, and those that are most at risk are the ones that really have to do what they can to protect themselves. I mean, unfortunately, that we've come to this point, but it is need to do the best to do the lives. So hopefully isn't a very adverse consequence.
It's sort of interesting from like what are we like globally, or what's happening around us as far as like mandates and things like that. So I work at rural LA, and most of the healthcare system mandated the primary vaccine series. They have not mandated boosters at all. So and for good or for bad or whatever, they said it made some sense to mandate this, but it doesn't. They have not mandated boosters, so we know how strong it is here one or another. Flu shots are mandated. If I chose not to get a flu shot, I get fired. So I had to get a flu shot this year. I didn't have to. And that's kind of where healthcare is. So I don't think doesn't seem like there's any mandates in the future that I've heard of that say, yeah, you should get mandated boosters that or the other way. But so that's, I mean, like my 2 cents over there.
Right. Mandates. People want to go back.
But yeah, but I mean, it's interesting, right? I mean, for 10 years, Aurora's mandated flu shot. So they said, hey, if you don't want to get flu shot, you can go somewhere else. So I mean, we already had that in place. So it's like, the people who are working there are already saying, yeah, let's get vaccines.
We can also, Mike has a question on the chat. He had said he had wanted to know if we are bringing anything forward to the ARPA slash Spirit Fund as a request, and just want to address that question that you put in the chat.
Yeah, Mike, executive, there's a placeholder for some public health funds to be utilized. Don't know how the ARPA Commission is going to allocate those funds or recommend allocations to the county board. Based on the last ARPA meeting, they've allocated far more funds to initiatives than was originally projected in, I think, some of the early planning. So at this point, do we have anything specific? No, we have, we have information to share. We also have COVID funding part of our response yet to utilize. I think most of our recommendations for ARPA funds are going to be to help place those funds in the community that really support initiatives that help people, recover, access basic needs, address the social determinants of health. And that's where we're hoping to see those funds go. There aren't a lot of infrastructure needs that we can address with our current funding. We are looking at software. We're looking at ways that we can invest these short-term funds to hopefully give us a little longer-term impact. So hopefully that helps. But happy to talk more offline.
I mean, I can go through the last.
It's not.
All right. PowerPoint it. So communicable disease. We work with health promotion, research, surveillance, monitoring, analysis. I'm not reading through it. Go to the next slide.
We'll send you a copy.
So send you a copy. Public health works more with the population. We're controlling that for the entire group. Prevention and health promotion is the big one. Whereas clinical health, you're dealing with the individual in front of you. And like always, those overlap. We're always looking for a little bit of both, but that is our general focus. Next slide. Infectious diseases. You have a susceptible host, protective environment, and a pathogen which creates disease. Within that, we do have methods of contact and how it is transmitted. We have direct person to person, which would be through blood or body fluids. Requires that direct physical contact. We have the indirect, which comes in different forms of like airborne coughing, sneezing, coughing, droplets in the air, oral fecal route, which we see a lot of with our long-term care facilities, all the diseases that come through that. We see children, daycares that'll come through. We have vector-borne, the mosquitoes, the ticks. Next slide. We need to do that and follow through with communicable disease due to our administrative from Department of Health Services and our state statute, chapter 2. Those cover the requirements that we must follow, and within each local health department, you figure out ways to meet that, and that's one code. Next slide. We have the Wisconsin mandatory disease reporting, and those fall into 3 different categories. In category 1, those have to be reported to us within 24 hours, and that's only by phone. That would be from anyone who is doing the testing or who has suspects. That comes to us from physicians, long-term care facilities, and anyone testing. Next slide. So those category 1 diseases, big ones that we're always looking for: tuberculosis, measles, meningitis, pertussis, polio. There are quite a few. They are urgent public health matters. Those must be reported by the telephone, can't be faxed, can't be waiting for it to come through a lab report. Those have to be identified. Now, we annually get calls on something like pertussis or meningitis. Pertussis, we get whooping cough because it's on a regular respiratory panel. So when you go in and you're sick and they draw that blood work, if the physician actually thinks it's whooping cough, they have suspected that maybe, they're going to call us immediately, well before the test is complete. And they're going to instruct that individual on what they need to do. But we still want to know and follow up. Meningitis, of course, we always get calls on that. Meningitis, we're really looking for is the Neisseria and bacterial infection. Those are the ones, again, just because meningitis doesn't mean it's highly communicable. Neisseria is very highly communicable, one we look at right away. The Haemophilus is the other one, and those are both bacterial. There are other bacterial meningitis that we aren't as, they are category 1 diseases. This also includes some of the outbreaks that we see in long-term care facilities on food or waterborne illnesses, and we follow up with that very quickly. Category 2 diseases, next slide. Those, again, cover there's 72 different, over 75 that are in that category. Those would be reported to us within 72 hours. That can be faxed, comes through in WEDS, which is our Wisconsin disease surveillance system. We follow up on those. Our sexually transmitted diseases also need to be followed up on, and we make sure that they're treated. As you see, Sam and Ella's Diner is not a good name. Try to put a little humor in that one. But if you click on that disease reporting, Wisconsin Department of Health Services, that shows on the bottom of that web page which diseases fall into what categories. Next slide. They stop the spread of disease. That's our goal. Do we always stop it? No, but at least we're slowing it. When you do have those outbreaks, you're trying to mitigate and follow the mitigations. So we slow those. We have better methods. As time's gone by for PCR and genome sequencing, which helps us decipher where these are coming from and how it's spreading. And then there's always new and emerging diseases. So we're looking at patterns to see if something is up and coming, where it's coming from, and it usually is like an offshoot of a previous disease. And then working at educating people in all different kinds of facilities, what they can do to help mitigate those measures. Next slide. All the information we give, I love to receive information on new research coming out. Please read this. I'm happy to read it. Now, again, a lot of the information that I'm receiving are stuff on preliminary. Anything that I take action of and endorse has to come from our agencies, professional groups, our credible journals, and research centers. This is not an all-encompassing group, but these are ones that I mainly look at. Looking at things in Google search. if they're coming from these organizations, that gives me a feeling of trust. They've come, they're peer-reviewed articles, which is a very stringent standard, not just meeting things that a layperson would think of, but that research has been with a large enough group to ensure reliability and validity, which is not the terms that we would understand those to be. Reliability is that they can continue to do the same test on different groups and have the same outcome. Validity is that you're testing and actually would be getting answers from your testing what you think you're testing. Those are very, very stringent. Next slide. We are always looking at those vaccine preventable diseases and what we're seeing over time. If you notice on the varicella on the far right, I have it halfway covered in the early years from 1978 because we weren't getting the reportable diseases, so we weren't getting those numbers. In 1993, 1994, we're having 11,000 varicella, and now we're down to about chickenpox. In 2018, there was 290. We are seeing outbreaks. Measles. It's a big concern. Go to the next slide. Measles outbreak in 2019. We also see it again now. We're watching for that. We were bracing for that in Wisconsin. We've seen it in Minnesota, Illinois, and Michigan. There's currently another big outbreak going on in Ohio. So we are preparing for that. We know it's going to happen because we do have large pockets of unvaccinated groups and unvaccinated children, and transfers is very highly transmissible. We are also seeing, if you see those items, those are clickable links. Polio is making a comeback. They've had in New York. So we'll keep an eye on that. And that is what we do. That's what we follow, those trends. Next slide. Oh, I did go fast. And those then are my links, and so that I can easily pull this down with my fingertips. Any questions?
Yes.
Yes.
You mentioned chickenpox, and there's the Shingrix things that all the advertising say, if you're over 50, if you're over 50, my daughter doesn't turn 50 until later this month. And my son is only 45, but they both had chickenpox. He got it, of course, because she brought it home from kindergarten. Should people who had chickenpox, even though they're under 50, should they be available? Should they be able to get that Shingrix vaccine to avoid shingles? All the advertisers say, if you're over 50, if you're over 50, but there's a population of people under 50 who did in fact get chickenpox, and I would assume are candidates for shingles.
Now, chickenpox then is least dormant, so it's in your body, and you then have that outbreak of shingles later. Usually brings on by stress, age, and more. But we do know as you get older and you get shingles, there could be stronger long-term effects. Talk to your primary care physician. We always suggest that you take the shingles earlier than that. A lot of times it's decided upon based on your other health concerns and immunosuppressive. They'll encourage you to have that, and you can get it. I myself have had shingles in my late 30s, and I've had the Shingrix earlier and later. It was.
So that vaccine could in fact be available to people under 50 if their healthcare provider says so.
Right.
And if you're under 50 and your healthcare provider thinks you should have it because you had chickenpox as a small child, does that mean the insurance won't cover it because you're not over 50, or do you have any idea about that?
It would be covered if your physician is their reasoning, and they do. It's covered.
Actually, no, it's like I mean, I want people who are covered with vaccine. It's up to the insurance provider, and insurance is based on basically the U.S. Preventative Task Force, and they've only recommended that.
Well, I have no control over my children. They're so almost 50 and 45. So what
you'd have to do is.
I don't see my kids doing that. But I do keep thinking, why do they keep saying over 50? There's a population of under 50 who were around, like my son, an older sibling, It's not quite 50 yet.
Because the adverse effects are something greater than under. They can weather the storm at 48.
That's what it is?
Not at 68. Yeah, the data shows. At a higher rate.
And not only that, when you're over 50 and you've gotten shingles, the chance of long-term effects of it are much greater.
Yep.
If you're under 50 and you get shingles, generally don't have.
I thought they were going with the 50 because it was within a few months after she had, my daughter had chickenpox, there was then a chickenpox vaccine came out. So those people who are over 50 have had the shot, assuming you didn't get it, you know, when you were still maybe, 4 or 5. Or you were the younger sibling who got it at 2. Okay, that's what it is. All right.
Question, I guess, Ashley, surrounding Hep C. So that that's a category 2. Okay, so that would be so we would have data on Hep C cases in the county and that type of stuff because of reportability and
It's mandated.
yeah. Okay. And then as far as like treatment for Hep C, do we have any good treatment streams?
Doesn't matter. We know that.
Well, and I mean, just providers who will provide the service. I mean,
I don't know about accessibility of treatment. I would assume that we do, but that's not something we would do.
Amanda. So Amanda is our harm reduction program coordinator, and she worked at Vivint for several years, Vivint Health for several years before coming to us. And so she's got built-in connections, more so in the Appleton area, but she is working on building up her provider resources for referrals for treatment, and they do get those results.
yeah, because I mean, I know that's been a significant struggle. It's nice to know that you have something, but it would be even nicer to know that you can do something about it. So yeah, I know actually starting to but I mean, I think that's one of those too, where it's like, okay, if we're doing stuff, we're measuring stuff, but we can't do anything about it. That's not good either. Well, and I mean, ours was actually, a lot of our treatment was being done in GI, and there's been a really shortage of GI providers in this county, in this area. So and actually, like, yeah, our infectious disease base, I don't take referrals for Hep C unless they have other stuff like HIV and together and stuff like that. Kind of goofy because, like, okay, it's a disease. Aren't you an infectious disease?
They're prioritized.
Yeah, so we could take referrals. What we're basically, because we're something we're basically have substance abuse and Hep C just to do that.
Well, the Hep C testing that we're doing is only on our, so they're only
yeah, so yeah, so we could definitely do that. So I'll talk to you later about that.
Careful, yeah, and it's recorded.
Yeah. Yeah, we actually have some.
Staying, we're gonna everybody's gonna give also.
Okay, I was going to talk about public health transformation and modernization. And so what I'm talking about is public health very broadly. It's less about our health department. It is about local health departments, but across like in our country. So kind of big that means for us.
Mm-hmm. Yes.
So this is some of the questions what are the responsibilities of the local health department? What is the impact of COVID and what's that had on our local health department, generally speaking? What is public health infrastructure? There's just been a lot of talk about because of COVID, we need to improve our infrastructure. What are the challenges facing a local health department and what is transformation and modernization look like? So the responsibilities of a local health department, this is very general. Our tagline is prevent, promote, protect. And so here are some examples of what that looks like. Prevent the spread of disease. We're ensuring food, air, and water quality are safe. Promote and support maternal and child health. Improve access to clinical services. Prevent chronic disease and injury, and provide protection and services based on our community needs. That would be our community health priorities. Next slide. So this is from a national group, and it's looking at public health nationwide, but that really COVID exposed the infrastructure, workforce, and systems that they're outdated, they're insufficient, and they're in need of transformation. Public health provides services. And so we need the necessary infrastructure. This is data sources, robust laboratory capacity, preparedness, policy planning, as well as staff. It's just that when we talk about public health infrastructure, what that means. So it includes systems, competencies, frameworks, relationships, and resources that enable us, public health agencies, to perform our core functions and essential services. So infrastructure includes our human resources, organizational resources, informational resources, legal, policy, and business. This is a slide of essential services. Again, this is a national model, and our core functions. The core functions are in green: the assessment, policy development, and assurance. Those are the roles that we play. And then underneath are the 10 essential services. So we assess and monitor the population health status. That's something that communicable disease does, that we just heard about, monitoring the disease. What's category 1, category 2. We investigate and diagnose problems and health hazards. That's a lot of what Ann does in environmental health. We inform and educate people about health and factors that influence their health. We mobilize communities. Our community health and prevention team works, does a lot of community engagement, working with community partners. And we create champion plans and policies and laws to improve health. As far as assurance, it's we use legal and regulatory actions that we have access to services and care for our community and for our population. We build and support a diverse workforce, continually improve, look at research to inform our decisions, and build and maintain a strong organizational infrastructure. So what are the challenges facing the local health department? And so, really from COVID, public health became more visible to everybody, but it's also misunderstood. Public health is really like public safety. So the fire department, the police department, public utilities, our power grid, our water supply, and other public goods, roads, sewers, and there should be a foundational level of public health services that must exist everywhere. And so we're talking across the country for services to work anywhere. So it's integrated, so you can count on your neighboring counties. If somebody moves, that you can count on getting public health services in a different state. And that's how other public services work, in public goods. we've known this for a long time, but that is public health has been underfunded and our systems are outdated. And there's gaps in our workforce. And again, that gaps in facilities. A lot of turnover in the state, in our state. And part of that is because of COVID. And so we need to do a lot more recruitment and then retention. So these are what's called the foundational public health services. There's about, so it's kind of hard to read. It's there'll be a link in the notes. So this is a framework for local health departments. The idea is to help them transform and modernize. It's really divided in parts and these at the bottom. And so that's the base really. So those are the skills and capacities needed to support basic public health protections, programs, and activities. And so in this handout, I mean, it really shows the scope of what public health is. It's quite extensive. And then on the foundational areas, those are topic specific. They're programs and services that include community health. And it also allows for the community specific identified needs. So it's just, this has been recently updated. And it's really like, kind of what we do. And so it, there's just a lot there that, really shows kind of how the scope of our work in health center. Right? So really what these foundational public health services are, they're a minimum set of public health services to be available in every community. So that's, this is the goal, right? That wherever you live, that you have this access to a minimum set of services. So how would this transform public health? So they are agreed upon public health services. They align with national initiatives such as public health. It's an opportunity to standardize programs and services across different jurisdictions. With flexibility to adapt. And also it's aligned with Wisconsin Department of Health Services with our state and the Wisconsin Association of Local Health Departments and Boards. And they've adopted this framework. And so it's a way to process that to build. It's also aligned with our state statutes. So this is just kind of what that would look like. Next slide. And then as far as just modernizing too, these are some of the other ideas that we talk about in local public health that were public health 3.0. So it's the role of a chief health strategist in the community. And so it's looking really to work with community partners, to rely on our community partners and build those effective partnerships to integrate with healthcare systems, collaborate. That we also need to recognize and update our outdated systems to use more state-of-the-art business models and technology and that kind of thing. So that's really like kind of where not just us, but state, other health departments across the country are talking about this kind of thing in ways to work together to have more of a connected system. So where are we? We're working on the foundational capabilities. We've done a staff assessment. And so And when you look at those organizational capabilities, it's kind of, you know, it identifies that what those are. So it's around leadership, it's information technology, it's the workforce development, financial management, that kind of thing. And so we've been talking about that, trying to update our systems and increase our staff capacities around those kinds of things. We prioritize our community partnership and our community partnership development and engagement opportunities. Really, it's how we strengthen our public health system. And also, and we have been, but provide the community with programs and services which are really expanding those foundational areas. And so now that you know, we're looking at quality improvement in our foundation, in our areas of programs and services, and ways to better make sure that we're reaching the population that we need to reach. And there's, you know, a group that we're not able to reach. We try to identify that group and see what we can do to make sure that they're getting the services that they should be. Yeah, this is just the last slide, and it's just the definition of health. But you know, it's really about living long and well, and it's where we all live, learn, work, and play. And it's an opportunity for all of us to strive and thrive. So it's really, you know, thinking about in public health, about where we live, learn, work, and play as where health happens. And so we certainly rely on our, you know, clinical and healthcare systems, but you know, the majority of whether somebody is healthy.
I have a question that might be for, you know, like I know that we kind of talk a little bit about community health, especially from the state. And I was actually pretty surprised at the funding for was in the state, especially as opposed to like if you look at our neighbors to the west, Minnesota and Iowa, which one of the other states, both of them better than us, and are double what we're spending per person. And I'm wondering if we could talk about why are we spending so low? Is it a traditional thing, or is it something sort of reason for them? And is there anything you can do to help the whole other health?
Our investment in public health is low. Well, for two reasons. One, state funding for public health is extremely low. Almost all the programming that we have at the state level is federal funding. We don't allocate many dollars of our state tax dollars to public health. And that puts a high burden on locals to fund that at the local level using local levy. The amount of commitment to local public health funding varies tremendously across the state, and is part of the reason that, you know, say that we've seen local health department, we've seen local health department. And so we rely a lot on federal funding, direct federal funding, and federal pass-through funding from the state. The area that we can make the biggest difference is by increasing state funding to local health departments. That would make the largest difference. And then if there were some requirements about local funding, that would probably help. But right now it's very discretionary. Maybe if you want to say about that.
Oh, I was just pulling this up to demonstrate just in 2022, Nevada and Wisconsin were states for public health funding.
Well, I think it's an interesting thing. It's like, if you look at, like, if I was pulling up through the things, and they have the different amounts of different things. And it's like, yeah, I think if you, in this United Health ranking, which is by an insurance company, so government or anything like that, it's like, so Minnesota, I think, was the number 6 rated state. Iowa's the 15th ranked state. So they, I mean, both are stronger.
Michigan too.
But from a funding standpoint, they're spending twice as much. Politically, they're going opposite directions. So, I mean, I was quite red. Minnesota's being a lot bluer. We're kind of in the purple area. For some reason, we're not. So I'm a little confused. Why is that?
What was a great example? Almost $0 of state funding went into the COVID response. Almost entirely federal. If we hadn't had the federal dollars, it would have been interesting how that response.
Graduation system. So are you saying when we did the rankings on health, those were, what did you say those were? Were the states that were paying more better in health?
We invest less in public health.
Yeah.
So per capita.
That almost every state.
Then, yeah, right. Yeah. Okay. And
it's
when you look at those other rankings with how healthy we are then.
Yeah, I mean, I don't think it's definitely not a one-to-one correlation.
No.
So it's, but it definitely seems like the people who are spending a little bit more, like Alaska is not the top state in public health, even though they spend more money.
Right.
But it does seem like the states that are spending somewhat more tend to be ranking somewhat higher.
Yeah.
And again, it doesn't seem that it's sort of regardless of political affiliation. And I mean, obviously, Alaska is not a very blue state either.
Right.
So it's not just the really liberal states are spending
more
and
are healthier.
Yeah.
Lois needs to leave at 10 and was asking if we can address the next meeting time.
Yes, for the next meeting date, not anticipating anything urgent for January, so we could choose the February date.
So were we going to do more of these deep dives with the board when we didn't have voting freedom?
Yeah, absolutely. I mean, I will continue the overviews.
But yeah, anyway.
It's I don't know if we'll have any voting item in February either, but it's really up to the board. I'd like to be, we had some discussion last night. Yeah.
We said
yeah.
So if we choose in our lives to go to 10 every time.
Yeah, we could set that as just kind of a general expectation.
So do we set a date for February? There's not going to be a meeting in January, correct?
Third, it would be the 17th of February.
And it's 7:30 to 10.
We need a.
And then are there any Board of Health reports?
I would just like to request humbly, there are 3 seats for 5 county board members. I could not do that with my neck to see what was going on. I would ask your staff to pull back and save at least 5 seats for our meetings so we can see the screen.
Oh, yeah.
Well, don't move now, but
yeah.
I mean, when you've got 3 seats available for 5 county board members and the rest of the staff is taking up the space, they can see the screen. I don't know why I'm even here. Thank you. So moved. You have no more board members who can.
You don't have a.
We're here till February.
And we